Will be starting with the next lecture, and for that lecture I would like to introduce Dr. Nata Chandra Chimote sir. It is a great pleasure to introduce sir. He's managing director and consultant clinical embryologist at Vanshadhara Fertility Center, which was one of the first IVF clinic and test tube baby center of Vidarbha and Central India. He has credited first IVF baby ICSI, TC and blastocyst baby of Vidarbha, Central India. Sir has been associate editor for a journal, Middle East Fertility Society, and has presented and published various original research paper articles in international journals and international conferences of ASHRAE and ASRM. Beyond all that, sir is a true academician, a great human being by nature, and a person whom I admire and adore a lot. Sir, over to you. You can introduce the speaker of the session, Dr. Danilo.
Yeah. Good morning, everybody. Here I am to start new session with Dr. Colleen Lynch, who is PhD. She is the training and scientific manager at Cooper Surgical Fertility Solutions. She did her BSc in genetics and MSc in medical genetics at the University of Glasgow, PhD also genetics at the University of Kent. She provides professional education and training for all levels and disciplines working in AR physics, including hands-on workshops. She's working for 17 years. So here I present Dr. Colleen Lynch.
Dr. Colin, can you unmute yourself? Yeah.
Yes, I have.
Perfect.
Hopefully you can see my screen now.
Yes, it's visible.
Great. I'd like to say thank you very much to the organizing committee for inviting me to speak today, and thank you very much to the moderator for that lovely introduction. I'm going to be speaking today about PN checking, and more specifically, the idea of genetic or molecular PN checks. Just in terms of any potential conflict of interest, obviously, as the moderator said, I am currently a full-time employee of Cooper Surgical Fertility Solutions, but I do work in a non-commercial role in professional education and training. So in terms of the talk today, I'd like to discuss the current status of PN checking in the lab, discuss molecular PN checking, go through some of the current evidence and publications we have in terms of the efficacy of our current methods for checking fertilization before finishing and summarizing. So obviously to the audience this morning, we all know that successful fertilization is conventionally determined as 2PN with two polar bodies. And we normally perform this fertilization check at around 16 to 18 hours post-insemination. There's a variety of good practice guidelines available to us as embryologists. And ESHRA specifically says that embryos that are derived from 3PNs or where there's greater than 3N nuclei oocytes should never be transferred. And they also say that transfer of embryos that are derived from 1PN or 0PN oocytes is not recommended. And this is basically because haploid or triploid embryos can produce unwanted events. This can be implantation, which leads to miscarriage, or, of course, molar pregnancies as well. Cumulative Z scores have been developed to assess quality at the zygote stage, but essentially what we're looking for in our normally fertilized oocyte is that it should be spherical, it should have two polar bodies and two pronuclei, one being the female pronuclei and one being the male pronuclei. We want these two pronuclei to be juxtaposed. We want them to be around the same size and centrally positioned in the cytoplasm. And we want to see two distinctly clear visible membranes. And we also want to see the presence of an equal number and size of nucleolar PBs aligned at the junction, which has also been correlated with increased embryo competence. And I think in the lab, we tend to think of PN checking normally as a very quick and easy process. But of course, it has a massive impact in terms of the downstream cycle, in terms of what is considered as suitable for embryo transfer and what is essentially discarded from treatment at this point. And there's various things we can run up against. The PNs may be faint. We know that they can appear or fade asynchronously. Sometimes we have unequally sized or even micropronuclei that we may be uncertain as to how to score them. And also, we sometimes find that they may be vertically stacked. And obviously, we would want to rotate the egg to get a better look. And obviously, this is more difficult nowadays if we're using time-lapse incubation. And so we still do have some questions surrounding the current status of PN checking in terms of, are we checking really at the perfect time? Should we be doing multiple checks? The caveat obviously being that we don't want to disturb the embryo environment. More importantly, or arising more frequently probably, is how we manage embryos where we have sort of questions around fertilization. And we know it is an imperfect technique because we know from our data that about 3% of embryos which are biopsied are triploid. So these are embryos which are biopsied for PTTA or PTTM, sent to the genomics lab for testing, having been scored as 2PNs, but have actually been identified as being triploid. And we also know that in the course of standard IVF, we do sometimes get molar pregnancies from embryos that have been scored as 2PNs. So we know that there is an error rate in terms of embryos scored as 2PNs, but we don't sort of fully understand in terms of the embryos that are excluded from use, that were scored as abnormally fertilized oocytes, what percentage of these actually might be suitable for use. So now to discuss the concept of molecular PN checking or using genetic methodologies to check PNs. So single nucleotide polymorphisms, more commonly known as SNPs, are basically just single base pair changes that occur along a specific stretch of DNA. So these result from natural variation in human evolution and reproduction. They are basically a common form of genetic variation, and each person has about 4 to 5 million SNPs throughout their genome. And it's important to note that these are changes that, by definition, are benign, with no obvious effects on either the health or development of the individual. So as these specific variations occur in many individuals, these SNPs can then act as biological markers. So we can see here that each individual has a unique pattern of SNPs in their genome. And as I said, act as biological markers because over 99% are inherited directly from the parent. And this basically allows us to establish a method of assessing the paternal allelic contributions. And this is obviously a methodology that has been used for a long time with reference to PGT-M. But we can see here, in terms of PGT-A and next generation sequencing, if we also look at SNP sequencing data, we can get unique maternal and paternal alleles, and we can then look at this information in any sample that is sent to us and potentially show, as here, that a sample is actually a maternal haploid, or in the other example, a paternal triploid. So basically, next generation sequencing is used for PGT-A now, sequences at a pretty low read depth to give us information on our copy number variants. But if we include SNP assessment into this, as well as providing a secondary assessment of our aneuploidy, and that can aid too in removal of artifacts and accuracy of our mosaic calling. It also, in conjunction with using paternal DNA and maternal DNA, it allows us to basically assign the origin of the any meiotic aneuploidies. It allows us to identify all forms of triploidy and haploidy, not just the female ones. And that also obviously then gives us the opportunity to also assign what we would call genetic or molecular PN checking. So to go on now to discuss the efficacy of PN checking as we currently perform it, because we have a number of studies that have been performed in terms of morphological transfer outcomes from transferring blastocysts, which have been derived from abnormally fertilized oocytes. So generally speaking, we're talking about zygotes which were scored as 0 PN or 1 PN. So this particular study from 2015 was a retrospective study, and they wanted to evaluate the quality and clinical outcomes of cycles with 1 or more 1 PN compared with cycles with 2 PN embryos. One of the things that was noted was that the developmental rates of 1 PN embryos on day 3 and day 5 or 6 were significantly lower when they were compared to the 2 PN embryos. But the ongoing pregnancy rates achieved with 1 PN blastocysts did not significantly differ from the control groups. So when they transferred blastocysts derived from 1 PNs, they had healthy live births, no differences in terms of obstetric outcomes, a similar live birth rate to when 2 PNs were transferred. What was interesting was that there was much fewer 2P sort of molecular sort of 2. They didn't get any pregnancies from the ICSI-1 PNs, and that would obviously suggest that those were potentially true 1 PNs rather than misscored abnormally fertilized oocytes. And the conclusion of this study was that 1 PNs should be considered for transfer, but only if there was no 2 PNs available. Another study, similarly, looking just at morphology in terms of scoring and neonatal outcomes, was published in 2020. And in this study, similarly, the results show that we have similar outcomes in terms of pregnancy rates when we look at embryos transferred at blastocyst, which have been derived from 0 PNs and 1 PNs. But this study did find or did highlight a higher miscarriage rate in the 1 PN embryos, or the embryos that were scored as 1 PN. And they also noted that the not PN group had higher birth weights, higher Z scores, and a greater proportion of large for gestational age newborns. So this study was a bit more cautious. They obviously did achieve a significant percentage of healthy live births from transfer of blastocysts derived from 0 PN and 1 PN scored zygotes. But again, they strongly highlighted that 2 PN blastocysts should be prioritized because of the higher miscarriage rate and lower live birth rate after 1 PN blastocyst transfers, and the higher birth weight after not PN blastocyst transfer. But finally, to move on to some studies where these transfers haven't been performed just on the basis of PN scoring and morphology. So not just the ability of those embryos to reach the blastocyst stage, but actually performing genetic analysis before transfer as well. And this is a paper from 2017 from Capalbo et al., where they performed this molecular or genetic PN checking in addition to PGTA that they were performing. So this idea isn't a novel concept. It's something that we've been doing on and off in cycles for a while. And in this paper, we can see it's obviously smaller numbers here, but 13 embryos, blastocysts, which have been scored as 1 PN. 9 of these were actually molecularly scored as being 2 PN. And they also had 14 blastocysts, which were scored as 3 PNs, but 3 PNs where they had 2 normally sized PNs and then 1 which was smaller. So embryos where there was doubts whether it was a 2 PN or a 3 PN. And of those 14 embryos, 12 of them were molecularly scored as being 2 PNs. So overall, that added 21 embryos as being diploid with biparental inheritance to the embryos that could be tested for PGTA. And 8 of those were diagnosed as being euploid, just under 30%, which again is actually pretty similar to the rate that we would normally expect from checking standard 2 PNs. The important thing to note here is that in 3 cycles, the only sort of diploid, euploid blastocyst produced was actually from what was scored as an abnormally fertilized oocyte. So 3 cycles were rescued where there would have been no 2 PNs for transfer had we not also tested these abnormally fertilized oocytes. And in all, 3 live births were achieved from these embryos, 1 coming from a 1 PN zygote and 1 from one of these 2.1 or 3 PN zygotes. And I think it's also worth noting that this study includes zygotes scored using time-lapse incubation. So this paper concluded that these enhanced technologies incorporating ploidy assessment are effective at rescuing these abnormally fertilized oocytes derived blastocysts. And the final paper that I just want to bring to note is one again from 2018 incorporating genetic ploidy assessment into PGTM. And again, this is something that quite a few of us have been doing on and off in our embryology practice, but not really sort of bringing the data together. And what we saw here in this paper was that they tested 49 blastocysts derived from 0 PN scored zygotes and 15 that had been scored as 1 PNs. And they actually found 75%, 75.5% of the not PNs to be diploid with biparental inheritance, and just under 43% of the 1 PN scored blastocysts also to be diploid and show biparental inheritance. The conclusion here in this paper was that genome-wide haplotyping of the not PNs and 1 PNs increased the number of PGT-M cycles reaching embryo transfer by a staggering 81%, and increased their live birth rate by 75%. And again, they had about a third of their cycles when you incorporate the PGT-M result as to whether the embryo was suitable for transfer. About a third of their cycles would not have an embryo for transfer if they had not incorporated testing of these blastocysts, which were derived from abnormally fertilized oocytes. So just to summarize, if we look in total at the whole number of abnormally fertilized oocytes we have, not just those that reach the blastocyst stage, about 30% of those that are visually scored as being abnormally fertilized are in fact 2 PNs. We don't really understand what percentage of this is down to the methodology of the PN checking, probably the majority, in terms of us actually missing the true state. But given that we do also see this in time-lapse incubation as well, again, this could be down to less optimal use of time-lapse incubation, or potentially even a biological phenomenon where the number of PN does not actually always match the number of parental genomes within the zygote. But certainly, by altering our PN checking, we do have the potential to increase the number of embryos available for transfer for our patients. And this should be a straightforward addition to the embryology process, and hopefully to most PGTA processes as well. Thank you.
Thank you so much, Dr. Colleen. It was really a wonderful lecture. And it really gives you the insight for any embryologists who are working in the laboratory to look for fertilization at the right time, number one. Number two, one has to write down or document all the things like the positioning of clone nuclei, also see the polar bodies, see the perimeter space, and at the same time, one has to look into the NPBs in both the PNs, and then accordingly you can really make out whether you have abnormal fertilization or not. It is just not 0 PN, or it is not just 3 PN, it is not just 1 PN. No, the results which you have given is really very, very, very interesting. And for any laboratory, it is not possible for you to go for PGTA and all that. So visually or morphologically, one has to be very accurate and also have multiple examinations by 2 or 3 embryologists to really ensure that yes, you have very good fertilization or abnormal fertilization. That's the story. Now I would invite a few questions. If Rahul, are we allowed?
Yeah. There might be questions in. I'll check, sir. There are questions like Dr. Colleen, early or delayed PN feeding, embryos which are fading early or delayed, do you feel there is any evidence with embryo quality? Any studies with aneuploidies?
Yeah, so the data is still limited, as we can see from what I've presented. The main sort of endpoints that have been looked at are implantation, pregnancy, and live birth. And we certainly do see similar outcomes when we have good quality blastocysts that are derived from these abnormally fertilized oocytes. There's not a great amount of information in terms of quality, but a couple of the papers, one of the morphological papers that didn't use molecular checking, did say there were less good quality blastocysts derived from the 1PNs than were derived from the 2PNs. But obviously there was no molecular checking in those papers. So potentially the ones that have developed a good quality blastocysts are the 2PNs, and the ones that haven't developed to good quality blastocysts are the ones that are truly abnormally fertilized oocytes.
So, any questions you can take from your side, sir?
Yeah. Dr. Colleen, I would like to ask you, just very recently, I had seen a fertilized site with 2PN, and one PN was having just a big dot, no NPVs, just a big dot, and the other one was having irregular NPVs, like maybe 7, 8. Okay, so how would you call it?
Yeah, I think these are the questions that we come across as embryologists every day. You know, and I think the majority of people would just score that as a 2PN. As you say, within embryology, we tend to think of PN checking as quite an easy job. And as you say, we don't often go into the detail, especially with the abnormally fertilized oocytes, of saying, do we have two polar bodies or one polar body? And is there any issue with the NPBs? So as far as I know, there aren't any papers specifically looking, you know, at that scenario. I know that in my previous clinical practice, it would probably have been scored as a 2PN. But I think these are the kind of sort of zygotes that we need to really make note of and have data that we can follow up as well. Because again, I think it's just an example of how our morphological PN scoring could potentially, you know, be missing the mark sometimes. Because, as you say, it's clearly not an ideal situation. And I think it's worth noting as well that you know, although the data that has been published so far in terms of these abnormally fertilized oocytes, when they're molecularly scored as 2PNs, we're seeing pretty good outcomes. But obviously, it's not within the realms of possibility that there's something happening on a different genetic level that's causing the pronuclei to either, you know, appear too quickly, too slowly, or asynchronously, because again, clearly that's not you know, the optimal sort of pathway of development either. You know, but at this point, we have very little information in terms of what happens in between, in terms of the small detail like that. And it's only sort of the big detail of, if we transfer them, do we get babies, that has been looked at. But unfortunately, I don't think I could probably guess in terms of the scenario that you're given, but I don't have the sort of scientific information to actually accurately tell you what the most likely scenario is.
Well, thank you so much. Actually, I would like to ask you one more question. Rather, it's a comment on your topic, that to be or not to be, that is the question. This is what Shakespeare asked. Hamlet. Similarly, everybody becomes Hamlet in the laboratory, as far as embryology is concerned. And therefore, I would like to conclude this session by saying a very big thank you for your wonderful lecture. And one more thing, the conclusion is that, I mean, without going through all this PGT and all that, if you go for transfer or at least formation of blastocyst from 0 PN or 2 PN, that will be better. It will give you better outcome. I mean, just like that, isn't it?
Yeah, definitely. You know, we have the morphological papers, but now we've got some of the molecular data to back those decisions up.
Thank you so much. Thank you so much.
Thank you.